Hi, this is Professor Pope, and this is the third and last video for this week, week 7. And this one is on patient decision aids. So, in the last video, we talked about some of the problems that we have in terms of making sure that patients actually are informed about the health care that they're getting, and that the current doctrine of informed consent and the current implementation of informed consent doesn't achieve the goals. So this time we're going to look to some other mechanism, other tool that is thought and has demonstrated to help bridge that gap, and that's patient decision aids. So these decision aids are evidence-based educational tools. They take different forms. They might be just literature, just maybe sometimes a single sheet of paper, sometimes called an option grid, just laying out two options side by side, sometimes interactive websites or videos or apps. The idea is kind of the following, and I'll use this analogy again with the waiter, right? If the waiter just comes over and describes the food, it's kind of hard to really absorb that and make an informed decision. So it helps, and of course, most restaurants instead have a printed menu, right, with the names of the dishes as well as little descriptions of what the main ingredients of those dishes are. And then some restaurants even go a step beyond that, and they even have like little pictures of what the dish is. So you get a better sense of what exactly it is that this meal might be if you ordered it. Well, that's the idea, right, with patient decision aids, is you get a clearer idea of what it is that you're ordering. So this is just a couple examples. This is, again, like I said, one type of tool, one type of decision aid is just an option grid. This one is just comparing three different ways to deal with the hearing loss, right? In the first column, these are the benefits of hearing aids. And if you keep going down, I mean, I cut it off to fit on the slide, but if you keep going down, it tells you about risks and costs and other things as well. In the second column, you can compare hearing aids to assisted living devices. And then in the third column on the right, you can see, well, what could you do if you got neither a hearing aid nor an assisted living device. So it's basically comparing three approaches to dealing with hearing loss. And there's a ton of different tools. I mean, I encourage you just to maybe look around and see. You can find many available for free and just get a sense of how they might work. This is one about statins, right? And this is a really common approach that many decision aids take, which is they just have all these little dots, colored dots, and you would enter some information about yourself, your age, and other factors, and it would give you your current risk of having a heart attack. And then that would change, right? If you say that would be a risk without a statin, then you could compare that side by side with your risk of having a heart attack with a statin. But one of the things that this does is it's just very visual, and it says in terms of a 1 out of 100, percentage risk. It displays that in graphic terms, so you can see how, in very visual terms, how your risk might change if you took different treatment pathways. The key thing that I want to convey, though, is that the evidence shows that these work very, very well. There's robust evidence that shows that patient decision aids are highly effective. There's more than 130 randomized controlled studies that have been published. If you look at all those studies all together, the total study population is larger than 30,000 patients with 50 different conditions. Those studies have been reviewed at a meta level, right? So the science in them has been reviewed at a meta level twice by the Cochrane collaboration. And reviewing that, this Cochrane concluded the following. Using decision aids improves patient knowledge. Patients who use decision aids before they get a particular healthcare intervention feel better informed, are clearer about their values, have more accurate expectations from that healthcare, and make more value congruent choices. And they have lower decisional conflict. They have a less of a state of uncertainty about the choices that they've made. In terms of unwanted medical treatment, which we talked about in the first of the 3 videos for this week, informed patients, patients who use decision aids, request less aggressive treatment. One popular decision aid that's both been studied a lot as well as has some reasonable use are videos that have been developed by Angelo Volandes in a lab that he has out of Mass General. In one of his studies, which pertains to cardiopulmonary resuscitation, CPR, he reported the following. In a control group where patients just heard their doctor read a verbal narrative about CPR, right? We're going to, maybe shock you, maybe, do chest compressions, and they just described what CPR was and what benefit it might offer. About 50% of patients consented to a DNR order. But the patients who not only heard their doctor read a verbal narrative about CPR, but also watched a 3-minute video, which we would, for our purposes, we'll call that the decision aid. The consent rate went from 50% to 80%, right? So a massive 30% increase in the DNR consent rate for the people who all they did was watch a 3-minute video. So you could see that that decision aids, and this is just one example, decision aids have an enormously powerful impact on the decisions that people make. They reduce unwanted medical treatment. So it's been described as a paradigmatic change in healthcare delivery, which is a really strong statement, but the evidence really sort of supports this, which is we're actually making sure that the treatment we're giving to patients is treatment that those patients really would want. I like to make this, nobody's done this analogy, but I like this one, which, if you remember, there was this really famous commercial, maybe one of the 10 most famous commercials ever aired in U.S. television, when Apple Computer first launched the Macintosh. It's back, 30 some years ago. This big commercial with somebody running, and it's based on the 1984 book, the dystopian novel, but they said when we launch this, you'll see why 1984 won't be like 1984. And it seemed to be a little bit over the top for a commercial about a computer, but in fact, right when the first Macintosh, as compared to the computers like Compaq and IBM on the market at the time, right, really was very, very different, and really, really well received. Why? Because it was more graphic, right? It had these little icons, way more user-friendly, way more accessible, right? It had a mouse, and computers didn't really have mice before that. It's just way more usable. And I think this is also the features that would pertain to decision aids versus multi-polysyllabic discourse. Unfortunately, despite their demonstrated benefits in terms of informing patients and making patients feel more confident, they're really underused, right? We have a lot of studies, but not a lot of usage. Great evidence, but very little clinical usage. The Institute of Medicine, right, one of our think tanks, about healthcare, right, laments that the promise of decision aids remains elusive. So few clinicians are using them. The goal of a lot of policymakers is now to move them from research to practice, to move them from the lab to the clinic. So how are people promoting decision aids? Well, the current law doesn't provide all that much incentive because, as we discussed in the second video, right, it's enough to make a disclosure. Even if it's a crappy disclosure, it's legally sufficient to make the disclosure. So it's not clear how much incentive there is to use a decision aid. So the innovation may be that we need to actually change the law in order to put some extra incentive to use decision aids. Now, the law isn't the only thing that we need to change. We need to change, training of clinicians and the culture and things way broader than the law. We need what some people have called a comprehensive strategy to promote wider uptake. But the law is definitely at least a piece of that puzzle. And there's three different types of laws, that are being innovated in terms of promoting decision aids: liability tools, payment tools, and mandates. In terms of liability tools, those can work either as shields or as swords. Right? Those are the basic two ways in which the law might work. As a shield, it might work as follows. And we have an example from the state of Washington. What Washington did was enact a statute which basically offers physicians who use decision aids safe harbor protection, legal protection, for using a decision aid. So if you use a decision aid, a certified decision aid for a particular healthcare intervention, that creates a presumption that you fulfilled your informed consent duty. And that presumption is hard to overcome. It's rebuttable only if the patient has clear and convincing evidence that you did not fulfill your informed consent duty. Normally, right, they'd only have to prove that with a preponderance of the evidence. Now they have to prove it with clear and convincing evidence. In other words, 80 to 85% likely that you didn't fulfill your informed consent duty. So using a decision aid creates a strong presumption that's hard to overcome. Also, there could be legal tools that would allow PDAs to be used as a sword to incentivize their use. So the example here would be from Texas. In Texas, they have a lot of healthcare interventions that are defined in terms of their specified disclosures that you have to make. This is one for hysterectomy. So basically, there are these forms and documents that have been developed for a whole bunch of different healthcare interventions. And in Texas, it works as follows, which is if you don't use the form, then that creates a presumption that you violated your duty. So it's the opposite of the way it works in Washington. If you use a decision aid in Washington, that creates a presumption that you satisfied your duty. Here, the failure to use a form creates a presumption that you violated or failed to fulfill your duty. This hasn't happened yet in Texas, but instead of just using forms with just text, they could instead use decision aids to convey what the content of what they think needs to be conveyed in Texas. So we could have both carrots and sticks. Another way to say shields and swords, carrots and sticks. Carrots to get the horse to go, and we provide enhanced malpractice protection for using shared decision-making and patient decision aids, so that Washington has taken a carrot approach. And I've suggested that perhaps Texas might consider taking a stick approach, that's another way to get the horse to go, which is to hit it with a stick. And that would be expanded malpractice exposure for failing to use shared decision-making and patient decision aids. Another a way to go would, instead of liability tools, whether enhanced penalty or enhanced protection, would be payment tools. The idea here is basically if you don't use the decision aid, then you don't get paid, or at least you don't get paid as much. Now, there aren't a lot of examples of this, just a handful. One comes from our big payer out there, CMS, right, which covers 56 million people under Medicare. And there's a couple examples where they would say that using a PDA is a condition for payment. One would be for screening for lung cancer with low-dose computed tomography. That one of the things you have to do, not the only thing, right? You obviously have to make sure that the patient is eligible and this is an appropriate intervention for them. But in addition to all of the clinical tests, to making sure that it's a clinically appropriate diagnostic tool, you also have to make sure that the patient wants it. Well, how? By using one or more decision aids. Also, another example of a CMS procedure, left atrial appendage closure therapy. Again, make sure not only that it's clinically indicated, but also make sure that it's preference indicated by using a formal shared decision-making interaction using an evidence-based tool. Use a patient decision aid, or we won't pay you for using this because we won't be confident that the patient actually wanted it. Those are federal Medicare examples, but we also have examples from Washington State. Washington State covers about 30% of its citizens through public payment programs. And that's a lot of people. That's over 2 million people covered by the state of Washington. And about 10 procedures now, actually a few more than that, are covered, meaning there are certified decision aids for at least 10 procedures. The state, as a purchaser, can then say, we're not going to pay for the administration of these 10 procedures unless you use the certified decision aid for those 10 procedures. So the state really can therefore act as not just impact the people it covers as a healthcare insurer, but also really acts as a first mover. And that may in fact create the ball rolling such that if all the physicians use the decision aids just because they contract with the state of Washington, then ultimately that may help push and evolve the very standard of care in the state of Washington. And then in addition to liability tools and payment tools, a third way to go would be mandates. So many states, like California, for example, specifically mandate that if somebody's getting a certain type of intervention, that a particular piece of literature be given to that patient. So this is just one little booklet from the California Department of Public Health on breast cancer treatment, right? And these mandates come from the licensing board. So they're not even liability mandates like we talked about in Texas, right? These are medical licensing board requirements such that you could be sanctioned under your license for failing to follow these rules. Well, the idea here is we're already mandating that certain pieces of documents be given to patients in certain situations. Again, we could use decision aids instead of just text-heavy booklets. Again, few tools are being deployed right now, and there might be an explanation for that. It might be a big obstacle that is in the way of broader deployment and use of decision aids, and that's this. Unfortunately, there's a lot of decision aids out there, and they do widely vary in terms of their quality. So we have a lot of different developers. Some are for-profit, some are non-profit. This is just, there's many more than this. It's just some of them. Well, here's the problem. We can't really attach legal consequences, whether a liability penalty, a liability benefit, or otherwise, to use or non-use of a decision aid unless we're confident that the decision aid is good and it is worthy of having an impact, a legally significant impact. So we need to assure PDA quality before we attach legal consequences to use or non-use. The way to ensure PDA quality is through certification, right? We need an independent entity that can review the decision aid and certify that it is good. We want to know that the decision aid is accurate, right? The risks, benefits, and alternatives are accurate, complete, and presented in a way that is understandable. We want to know that the decision aid is free of bias and free of conflict of interest. And we want to know that the decision aid isn't just there to convey information, but is actually there as a tool that can help the patient, assist the patient to clarify their own values and preferences and make a decision. So in 2010, you'll recall that President Obama signed the Affordable Care Act. In the Affordable Care Act, which, by the way, of course, we still have, at least for right now, in the Affordable Care Act, is a section 3056, and in that section of the law of the bill is this, which is it directed CMS, it directed the agency to contract with an entity to synthesize evidence and establish consensus-based standards, which is basically contract with somebody to designate them to be the official certifier of decision aids. And the idea would be, basically, if we certify decision aids, then people will use decision aids because they'll have confidence in them, and then there'll be less unwanted medical treatment, and Medicare won't be spending money on things that people don't even want. Unfortunately, fast forward 7.5 years later, we still have no criteria, no process, and no entity for certification. But that's the bad news. There's a silver lining. Things have moved forward in the state of Washington. In Washington state, they have all of this. So they've drafted certification criteria. They have a process for certification in their state healthcare authority. They even use the process, use the criteria to actually certify decision aids, and they've actually certified some. Last year, they focused on decision aids related to labor and delivery. They certified 3 related to prenatal testing and 2 related to birth options, focused primarily on vaginal birth after cesarean. This year, they focused on joint replacement and spine interventions. And next year, they're going to focus on end-of-life interventions. So Washington State is really paving the way in terms of showing how we can certify decision aids and how we can incentivize use of those certified decision aids. Hopefully, back in the other Washington, in Washington, D.C., they can learn the lessons and follow the path that Washington has paved for it.